Hello, everyone. I'm Jeff Kaufman. I'm the Executive Director of the Adenoid Cystic Carcinoma Research Foundation, or ACCRF. In case you're joining us for the first time, my wife Marnie and I started ACCRF after she was diagnosed with ACC in her right parotid gland in 2004. She was 38 years old, and we had 4 boys under the age of 10. The following year, after Marnie had completed her surgery and radiation, we decided to accelerate ACC research by starting the foundation. Over the past 17 years, patients and researchers have joined together to work on ACCRF's mission to find better treatments faster. ACCRF has supported research to understand the biology of the disease. We've enabled preclinical testing of treatments, leading to a dramatic rise in the number of clinical trials. And we have educated patients about their disease and treatment options. We always say that research begins and ends with patients. So we're thrilled to have so many patients joining us for this webinar. More than 150 people registered from 24 countries. We truly are a global patient community. Today's webinar is the 4th in a series we started 1.5 years ago, covering topics that patients told us they wanted to learn more about. This webinar is about dealing with lung metastases. All patients and their loved ones are very familiar with the anxiety around the time of chest CT scans, the dreaded scanxiety. Will there be any spots that show up? How big are they? Are they growing? Should we watch and wait or take action? I know I've spent many hours squinting over digital images of Marnie's CT scans. Dealing with lung metastases, or METs, is one of the biggest concerns of ACC patients. We're incredibly fortunate today to have 2 clinicians, Dr. Renata Ferrarotto of MD Anderson and Dr. Jonathan Schoenfeld of Dana-Farber, to help guide us through these questions that came from you as you registered for this webinar. However, before we get to our panelists, I need to go over some housekeeping and context for the webinar. First, let's start with the housekeeping. As I said, the questions for the panel are drawn from the registration forms. Feel free to add more questions into the chat. We're fortunate today to have ACCRF Director Dr. Bojo Todoric monitoring the chat, and he'll pull out some questions of broad interest for the end if time permits. Please do not put any personal information, such as your medical history, into the chat or publicly disseminate any information from the chat. ACCRF does not provide medical advice. We seek to educate patients so they can discuss treatment decisions with an experienced physician in a private setting. Comments in this webinar from the physicians refer to broad patient groups, not to any individual patient. Individualized treatment plans should be discussed with each patient's own physicians. And lastly, this webinar is being recorded and will be posted on the ACCRF website, assuming there are no technical glitches. We'll do our best. So then quickly, let me give you some context on ACC and lung metastases, or METs. About half of all ACC patients will develop distant metastases, usually to the lungs. But that doesn't mean everyone will. So do not assume that you will get lung mets if you do not already have them. Now, so many patients are cured of their disease by surgery and radiation, but we don't know who those patients are. So it's incredibly important for all patients to have lifelong surveillance for recurrences and have their physicians keep monitoring them. Now, when we talk about metastases, you'll often hear terms such as progression or progressive disease or partial response. So quickly, let me explain what those are. Progression is when there's 20% or more growth in a tumor's longest dimension, or there are new metastases that show up. That's the not so good definition. The better definition, the happier definition, is partial response. And that's when tumors shrink by 30% or more when, in response to a treatment. About 1/4 of ACC patients with metastases have aggressive tumors with solid histology and/or activation of the Notch gene. Now, these aggressive tumors, they do go to the lungs, but they're also more likely to show up in the liver and bones. So they're a slightly different mix of metastases that happen with the aggressive ACC. Now, you just heard me mention the Notch gene. Whenever we talk about genes or DNA, we also want to be very careful that patients understand that while cancer and ACC is a genetic disease, that does not mean it's an inheritable disease. The changes in the genes are just in the parotid gland or the lacrimal gland, the mammary gland. They aren't in the reproductive cells that get passed on to future generations. So we don't consider ACC to be an inheritable cancer, just as we don't view it as a transmissible cancer by kissing or touching or anything like that. My last point I'd like to make is that ACC research is very active with many new therapies in development. Both doctors Ferrarotto and Schoenfeld have very active research efforts going, as do many others. So patients should really feel some justifiable hope for the future. Now, I do want to give a quick overview of the approaches to treating lung mets. We generally think of 4 approaches: surgery, which could be wedge resections and lobectomies; radiation, which can either be external beam, like SBRT, where the radiation is being beamed into the tumor from outside the body, or it can be internal, like brachytherapy, where seeds or cathodes are put into the tumor and the radiation is delivered internally. The third category is interventional radiology, where the tumors are either heated up with radiofrequency or microwave ablation, or they're frozen with cryoablation. And lastly, there's a very broad category of systemic therapy, and that's where the treatments systemically go throughout the whole body. And those include chemotherapy, targeted drugs, and immunotherapy. I want to quickly point out a few websites that may be particularly important for this group. We have an advanced disease webpage. We have a webpage that discusses radiation therapy. We have a page that discusses systemic therapy. And I think there's a very useful page on clinical trials that are open that patients can discuss with their treating oncologists to see if they might be appropriate. Now let's focus on the real purpose of today's webinar, the panel discussion. I'd like to turn things over to ACCRF's Director of Research, Dr. Nikki Sparty-Burr, to introduce our panelists and moderate the session. Nikki?
Thanks, Jeff. I'd also like to welcome you all to the webinar and thank those of you that submitted some really great questions. Panelists, you may now turn on your video and microphone. It's my pleasure to introduce our panelists today, Dr. Renata Ferrarotto and Dr. Jonathan Schoenfeld. I'll list each of the speakers' affiliations and then invite them to share a brief introduction. Dr. Ferrarotto is a thoracic head and neck medical oncologist at the University of Texas MD Anderson Cancer Center, where she also serves as an associate professor and director of the Head and Neck Oncology Clinical Research Department. Dr. Ferrarotto has led multiple ACC clinical trials and was one of the first researchers to describe the importance of activating Notch1 mutations in ACC. Dr. Schoenfeld is a radiation oncologist at the Dana-Farber Cancer Institute and associate professor of radiation oncology at Harvard Medical School. Dr. Schoenfeld has also led multiple ACC clinical trials involving radiation and has published on the immune microenvironment and oligometastatic disease in ACC. I want to thank our panelists for joining us today to speak on how to deal with lung metastases. Next, we'd like to invite each of the doctors to introduce themselves and share a little bit about their experience treating ACC patients. Dr. Ferrarotto, you can start.
Thank you, Nick, Jeff, for the invite. First, I'd like to say that it's an immense pleasure to be here. I think that, we have been working together in many research projects in ACC, and I think that this foundation is just wonderful, for all the patients and all the physicians who have an interest in this disease. So thank you for your continuous support. So talking a little bit about myself. So I'm a medical oncologist. So I'm the chemo systemic therapy doctor. So that's my specialty. I have been at MD Anderson now for 11 years. And I have been dedicating to head and neck cancer for 9 years, and specifically within head and neck, my major interest is in salivary gland cancers and other rare cancers. Given my interest, and because we're a reference center, I do see a lot of patients with adenoid cystic carcinoma. I have 2 clinics a week, and in every clinic I have patients with ACC. So I have a very strong interest in really move the needle and find new therapeutic options so we can, improve hopefully the treatment options and cure rates for patients with ACC.
Okay. Well, again, I'm John Schoenfeld I'm a radiation oncologist in Boston at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And I also want to thank Jeff and Nikki and the ACCRF for the invitation to discuss this morning, the problem of lung metastases in ACC patients. I also, I've been at the Dana-Farber and Brigham for over 10 years. I specialize predominantly in head and neck cancers and see a lot of salivary gland cancer patients, including ACC. And, for my entire career, even going back to training, that's been a major interest of mine. And also looking at ways we can improve how we give radiation, either through new technologies that we can use to try to increase the effectiveness of radiation and decrease side effects, or by combining radiation with other types of, drugs or agents that might also increase how well radiation works. Again, it's really a privilege to be here and, to work on the research that might benefit patients in the future.
Thank you both for those great introductions. And now let's start the question and answer portion. The questions have been divided into 3 sections. First, we'll focus on surveillance and diagnosis of lung metastases, then on the natural history of lung metastases, and finally on treatment options. I'll direct the questions to specific panelists in rotating order, but both panelists should feel free to weigh in on any question after the designated speaker has finished. Okay, so the first question on surveillance and diagnosis of lung metastases goes to Dr. Ferrarotto. How do you typically monitor patients with no evident disease for new metastases? Which types of scans, CT, MRI, and/or PET do you use, and how frequently?
Okay, great question. So typically, when patients finish the treatment, usually surgery and radiation, we do the first scan about 3 months after, and that usually we scan the area that where the primary tumor used to be that was treated. So most of the times it's going to be in the head and neck, but if it's a tracheal cancer, it's the chest or breast, but usually head and neck. So for head and neck, I tend to do MRI to monitor the primary site, and we do that every 3 months during the first 2 years, and then the 3rd year we space that out more, every 4 to 6 months. The 4th and 5th year we tend to do every 6 months, and then thereafter, if no evidence of disease, we do it yearly. And then beyond that, we tend to do every 6 months CT chest, so every other time when the patient comes during those first 2 years. So one time they do only the imaging specific to the site where the disease used to be, and the other time they do both the CT chest and the imaging of the local site. So every other time, every 6 months, we tend to do the CT chest, and every 6 months thereafter. There's really no guideline for this. A lot of this is extrapolated from, we had an squamous cell carcinoma. That's what we do every 3 months, at least, and even that is not is not the same everywhere, but that's usually how we do, in my institution.
A quick follow-up from the chat that's related to this is if someone had a very small nodule, would that change the type of scan or the frequency with which you're going to do the scans?
Yeah, great question. I think if a patient has a higher, chance of recurrence, I think we get more, we want to keep it more every 3 months, patients with significant peritoneal invasions, like big tumors, positive margins. Because a small early stage tumor in the parotid, I think, that can probably be less frequent. I have to say the surgeons still tend to do every 3 months in the first 2 years, but arguably one could say it could be done even every 6 months, in the first 2 years. So that's a great question. And in the modality, usually for the head and neck is MRI and for the chest CT, and I don't tend to use PETs on the surveillance. If we have no evidence of disease, not always ACC is seen on PET, it's not always FDG avid. And also scanning everything, the more probable place to come back is the lung, so we tend just to look into that part, although a CT chest really encompasses a lot more than the lungs. You can see most of the liver, you see the bony structures, that are in that area. Yeah.
Thank you. Okay, the next question is to Dr. Schoenfeld. When does a finding on a scan become worrisome and then highly likely to be an ACC metastasis? What do they look like? And can an untrained patient identify metastases?
Yeah, no, that's another great question. So I will say, it can be tricky, I think because there is no one feature that's really, that you can see on a scan that proves something is a lung metastasis from ACC. And it's common for people who have ACC or don't have ACC to have small nodules in their lungs or small findings in their lungs that show up on scans that have nothing to do with cancer. That's just common in the population. It's common in people that have certain exposures, a history of smoking, history of other infections. And those can be tricky because those can look like lung metastases in some cases. That's why it's important, I think what most places do and what we do is we kind of what's going on, what the patient's history is. We have tumor boards where we discuss scans with physicians who are taking care of patients, with trained specialist radiologists. Some things that are worrisome. The most worrisome thing is something that's growing over time. I think that always makes us worried. So if something is stable and if something is very small, we're less worried. If something is larger and growing over time, that makes us more concerned. If someone has another explanation, if they have a history of an infection, if they have another history that would make them give another explanation to have some findings in the lung, that makes us less worried. And then in terms of the way the actual nodules appear, there are some findings that make us a little bit more worried. Cancers that spread to the lungs from other sites, tend to be more rounded in appearance. They tend to be in multiple areas and not just in one area. So there are some features that you can see on the scans that we do look for, but that's not uniform. And so some cancers just don't follow the rules and look differently. And some things that are not cancer can look like cancer, some types of infections, some kinds of inflammatory conditions. So, really to summarize, we often will get scans over time and look to see how lesions have grown. We look to see the shape of lesions in the lungs. We look to see how many there are. And also we look at the broader, context. Does a patient have another reason to have these nodules? Does the patient, have a larger, more aggressive cancer that makes us more worried that maybe it has spread to the lungs? More aggressive genetic factors or tumor factors that make us more worried. So it's a variety of different things that we kind of all integrate together when we interpret scans.
Thank you. Okay. The next question to Renata. Do you ever confirm that a patient has a lung metastasis with a biopsy or some other method, and in which situations? Or do you just assume that a large finding is an ACC metastasis?
Yeah, I tend to biopsy to confirm. I think for the reasons that Dr. Chopper just mentioned. Although you have some clues, things are growing over time. Based on what we know of ACC, there are likely metastases, but I always like if it's safe, right? If there's no risk for the patient, if the biopsy procedure is considered safe, I try to biopsy. And I think that also can be helpful, particularly if there is a long disease-free interval, from when the patient had the primary cancer and then they developed the metastasis. And now that's what you're treating. I tend to study a little bit more the DNA background of the cancer that is in the lungs, because it may be a bit different than what it was there before. Sometimes those things change. So I think having a more current picture, of the DNA background of the cancer may be helpful. So yes, whenever safe to do, we recommend a biopsy, CT-guided biopsy.
Thank you. Okay, to Dr. Schoenfeld, can COVID or other infections be mistaken for lung metastases?
I mean, the short answer is yes. COVID not as commonly as maybe some other infections. As I mentioned before, we're a little bit more worried when there's more rounded kind of discrete areas within the lung, and COVID tends to be a little bit, at least the findings in the lung tends to be a little bit more kind of spread out, and not as discrete, and doesn't look exactly the same. So it can be, and after an infection, and particularly a severe infection, people can have changes in their lungs that take a while to resolve, that can make it harder to just interpret scans in general. The one we see some vaccines people can have, that's can be suggestive of an immune reaction to the vaccine. That can be sometimes hard and can show up on scans and be ACC less, because it's a type of cancer that doesn't spread as often to the lymph nodes, but it is something that can show up on scans. There are some other types of infections that do look a little bit more like, that can look a little bit more like metastases. And so those infections, not really, some pneumonias involve one area of the lung and not really the discrete nodules, but there are some types of inflammatory conditions and other infections, fungal infections, that can look more like lung metastases. So it's really the overall pattern, and again, the changes over time.
Okay, you are breaking up a little bit in the beginning, but I think you just summarized that nicely, right? Where there are infections that can, maybe look a little bit suspicious, but maybe less likely COVID, some other infections, but really it's capturing these scans over time that's really going to be the thing that helps you to, say we should take a closer look or think about treating. Okay. All right, moving on to questions on the natural history of lung metastases. Okay, the first is to Dr. Ferrarotto. What is the typical progression of patients who get lung metastases? How quickly do they grow? How many do they get?
Yeah, it's a great question. So in good timing, because we just finished, doing some analysis that ACCRF funded actually on to try to answer some of these questions. I prepared a couple of slides on that. Let me just share my screen quick. When I put on the presentation mode, it goes to the other screen. I may just leave on the slide mode. Let's see if you guys can see it. Can you see it?
Yep,
Yes.
it came through.
Perfect. Yeah, so we, in order to understand what's the trajectory of the lung metastases in ACC, so we looked in patients that came to MD Anderson, for which we had at least one pulmonary metastasis. There was at least 5 millimeters and at least 2 CT scans of the chest, so we could track the trajectory. And we did radiologic assessment, so radiologists actually looked into those scans and, evaluate all the lung nodules there from the beginning, from the first time that the metastasis was seen until when intervention was done, local therapy, systemic therapy. And then we calculated here what was the time to progression as assessed per RECIST, which is what the criteria that Jeff alluded to. So basically, in RECIST, we consider progression. We only measure the longest diameter here of the tumor. So basically, if this is a lung nodule, we would just put the ruler right here in the middle, in the longest diameter, and that's how we measure it. We choose 2 of them, and that usually represents the rest. And we consider progression per this criteria if there's at least a 20% tumor growth or any new lesion appearing. And we compared that with the calculation of the tumor volume doubling time. When you don't consider it's not only a unidimension measure, right? You consider the whole volume of the nodule. So here, I don't know if you can see in blue, the radiologist kind of circle around the tumor in every single slice, and there is a mathematical formula that you can predict, like 3D, what the volume would be. So basically, we had 75 patients that fulfilled this criteria that were available for this natural history project. So what we found is that 89% of patients had lung as the only site of initial metastasis. So the vast majority of patients that develop lung metastasis develop only the lung, at least as an initial site. And most of them had actually only a few lung lesions. In our study, we looked 1 to 4, about 65%. We then calculated if the tumor growth rate was constant over time. And there is some mathematical formulas that that you can use. And we found that about 82% of the times the growth was constant over time, so you could predict. And then we calculated the median time to progression. Again, 20% tumor growth were new lesions without any intervention. In our cohort was about 9 months. So it took out the median about 9 months for the tumor to have a 20% tumor growth or a new lesion to appear. And then we calculated the tumor volume doubling time. And then we calculated only 63 patients, just because for you to do that calculation, the tumor has to have a constant growth rate. So you can only apply that to the 82% that had a constant tumor growth rate. And the tumor volume doubling time, the median was 6.8 months. Okay. And what we saw here, that was also kind of predictable. We saw that the time to progression, or the doubling time, was a bit shorter for tumors with solid histology. So we know that, under the microscope, there are 3 main ways that the ACC can look like, and the solid tends to be a little bit more aggressive. So we saw that here too. And when we compared the time to progression with the RECIST criteria, which is the one that we use more frequently, versus the tumor volume doubling time, actually the doubling time was better to predict survival, so that it was more predictive of the patients that are going to do worse than the time to progression. Here's just some graphics showing, actually the first one showing that actually patients that develop only lung metastases versus lung plus elsewhere have a better prognosis, so they have better survival. And then here just showing that when you divide by the median, you really can't predict well by time to progression the survival, but the tumor volume doubling time you can separate better. Those that have a tumor volume doubling time more than the median have a better survival than those that have doubling time less than the median. And then, since a lot of the clinical trials, or even in clinic, the decision for us, to start therapy a lot of times comes with this 6 months time frame. So we usually use, if you're progressing within 6 months, we start therapy. We kind of use that 6 months cutoff for time to progression or doubling time. And both of them actually correlated with survival. So if a tumor is progressing within 6 months, we have a worse survival than those that are progressing more than 6 months, but the doubling time again performed better, and separate those patients that are going to do worse. So I think this is interesting data, and I think it may kind of guide better when it's the best time to start some systemic therapy. It has shown in thyroid, for instance, that this benefit of a pill that they give, that inhibit blood vessel formation, was only impacted survival on those patients with thyroid cancer where the tumor volume doubling time was less, than a year versus more than a year. So I think that may guide, us a little bit on when to start therapy, and also maybe more helpful to measure volume to demonstrate if the drug is working, because sometimes it's hard to capture that with RECIST. So these are some of the interesting findings, I think, from this work.
Thank you, Renata, for sharing some of this recent data from your lab. As a follow-up, why do you think the lungs are the most common site of metastasis for ACC?
Yeah, great question. I think all cancers have a preferential site, and I think it depends, a little bit on the cancer, on the genomic background, right? I mean, even within ACC, as Jeff alluded to, right? I mean, most of the times it goes to the lung, and most of the times it goes to the lung only. But as we described in the Notch mutants, they're more likely to go to the liver and to the bone. So, so the DNA background, so the genomics, I think, makes one organ have a more fertile soil for that specific tumor. So I think the tumors can grow better, in certain environments, right? So it's a combination of the tumor characteristics and the microenvironment of the target organ that makes them room to that place and facilitate the cancer cells coming out in that specific organ and having a growth advantage. So yeah, I think that's the best answer. I mean, like colorectal cancer goes most to the liver, some breast cancers like HER2 positive go most to the brain, and I think it's really a combination of tumor characteristics and the target organ that makes that soil fertile for that specific cancer, that specific genomics.
Good answer for a hard question.
Yeah, that's a hard one.
The next question is for Dr. Schoenfeld. A surgeon and radiation oncologist can eliminate a primary ACC tumor with very good long-term success. 5 to 10 year local control of the primary tumor in many series is above 90%. Once a patient has lung metastases, is it possible to control the tumor similarly as well?
Yeah. So I wish there were better data about this. I think it's hard because, we don't treat lung metastases the same way. So when a patient, generally is diagnosed with a primary ACC tumor, in a lot of cases they, undergo, or we recommend pretty intense treatment regimen, which is, surgery and then after surgery radiation. And, it's a relatively longer course of radiation because it's generally 6 to 7 weeks, in many cases of daily radiation. And like you said, we know with this kind of regimen, we're able to really control tumors in the majority of cases. We really have different priorities when when tumors have spread to the lungs, because we're not just thinking about the tumor in many cases in one area. We're also thinking about ways we can hopefully prevent the tumor from spreading to other areas or starting to grow in other areas. And, in that kind of setting, it doesn't make sense in most cases to really do the same thing we do at the time of initial diagnosis, and that's do surgery and then do a 6 to 7 week regimen of radiation, because we're ignoring the risk that the tumor comes back in other locations in the lung. And so we really do give a shorter treatment course, mostly with radiation or ablation. And the results, I think that the data that are out there show that it's quite good at controlling tumors, even though we're giving a lower dose of radiation and a shorter course of treatment. We're successful most of the time. And we did a study where we looked at a shorter course of radiation, given over a couple of weeks. And, even with that more focused radiation, we really didn't have anybody that had progression at the site that we treated locally. So I do think that, probably our results and control rates are very high. I don't know that they're quite the 90% or greater. And I think it would be a good area to study in more depth, but I do think it's very high.
Thank you. Okay. Again to you, John. Is it better to treat lung mets when there is only one or a few Can patients live longer if you immediately treat oligometastases instead of watchful waiting?
Yeah, so maybe I'll share a couple of slides here. I think again, it's a really good question that I wish we had, more information about. Can you see my slides okay?
Yeah.
Yeah, and I think that, the question goes to this increasing understanding we're getting about the different patterns that cancers spread. We used to have a more, I think, dichotomous view, so that cancers were either localized, in just one location where they started, or widely or had spread to multiple different locations. But in reality, I think that over time we've appreciated that there are these intermediate states, and two radiation oncologists, Sam Hellman and Ralph Weschelbaum, were one of the first to help define what we now call oligometastases. And that's not just in ACC, but in multiple different types of cancers, that there probably are a subset of patients that, at least for some time period, have cancer that may have spread just beyond the primary site where they started. In ACC, that's the salivary glands, but in other cancers, it's different organs. And that has spread to other parts of the body, but it hasn't really spread to the point where, local treatments like radiation or surgery or ablation, might be very beneficial for patients. And over the last, few decades, there have actually been a number of clinical trials that have been done in multiple different types of cancer, looking at radiation, or in some cases surgery. And the radiation is again, it's a more focused type of radiation, generally called stereotactic body radiotherapy, also known as SBRT or SABR, is another acronym that's commonly used. And in studies that have been done, giving radiation in various different types of cancers with limited metastases or oligometastases, might be beneficial. And the studies that have looked at this, is one, well-known study is called the SABR Comet study. And that wasn't actually limited to any single type of tumor, but included all different types of tumors. There's also been trials in prostate cancer, lung cancer, kidney cancer, that suggests that there might be a benefit to giving these patients radiation or SBRT, but it hasn't been all studies. So for example, it might be something that's specific for one type of cancer and not another, because there was another recent study in patients with oligometastatic or limited spread of breast cancers, and the radiation didn't show a benefit. So what do I mean by benefit? So these are data from that trial that I talked about, the SABR Comet trial. And in this trial, patients were randomized to either get just standard treatment or to get SABR or SBRT treatment. And you can see, if you look at, this is survival, so this is the percent survival on the y-axis over time in years. You can see that patients who got SABR tended to do better in terms of overall survival or time to progression, with a 22-month improvement in median survival. And then this is another study that was done in lung cancer. Again, looking at local therapy, so it didn't have to be radiation, it could have been other forms of local therapy, and just comparing it to standard therapy. And you can see again a benefit in terms of how long it took before patients progressed, or a benefit in terms of survival. And here there was a 24-month improvement in overall survival. So we also were curious about, does this apply to our patients that we see with adenoid cystic cancer? And I just wanted to acknowledge that there was a Harvard medical student that I worked with, Kevin Tyan, and we looked at this, and we wanted to ask a few questions and see, do patients with adenoid cystic carcinoma have a time where they often have oligometastases? I mean, we thought the answer was yes from our clinical experience. And then we also wanted to see what the natural history of those patients who have oligometastatic adenoid cystic carcinoma, and see if we could identify predictors of outcomes. And this was different. I just want to say this wasn't a randomized trial like the SABR Comet trial or the lung cancer trial. So there's some limitations that, when we look back and look at predictors of outcomes, we might treat different patients differently, and so that might be, responsible for some of the outcomes that we see. So it doesn't, prevent the need for doing it. I think a study in the future to look at this in more detail that I'll talk about. And so we looked at, we started out with our experience of over 120 patients with adenoid cystic carcinoma. And, we eventually had 42 where we had more comprehensive kind of records with disease that had spread. And actually, just like Dr. Ferrarotto, we saw that the majority of patients at least had a period of time where they were limited to, having just a few lesions, 5 or less, that we called oligometastatic within the lung. And in fact, if you look in more detail at what oligometastatic meant, is that we could, if we look back carefully at the scans that these patients had received, the majority had either 1, 2, or 3 lesions in the lung or metastases in the lung at a period of time. And we look to see, in our experience, some of those patients went on to get earlier treatment, earlier local treatment, either with radiation or surgery or ablative therapy. And we compared those to the patients that, didn't receive treatment as early. And what we saw is that the patients who had received earlier local treatment tended to continue to do better over time, shown in blue here, compared to other patients where they didn't receive local treatment as early. And that was in contrast to patients where we looked at if they received systemic treatment, so drug treatments, chemotherapy, or targeted therapy. And again, this is a little limited because these are patients treated over many, many years when there weren't the same treatment options that there are available today. But we didn't really see the same effect. There wasn't really a big difference. So that really inspired us to see if we could see the same benefit for earlier treatment with radiation or SBRT or local treatment for patients that just have less than 5 lung metastases or other metastases, so this oligometastatic setting. And so right now we have an open clinical trial we call the SOLAR trial that we're running through the Dana-Farber in conjunction with one of our medical oncologists, Dr. Glenn Hanna, looking to see, if we randomize patients with ACC who have less than 5 metastases, one, we could just treat them with, they could just receive treatment with standard of care. But if we add radiation early, does that provide a benefit? And I think it's important to do this study because, radiation, just like any other treatment, has side effects. And so we only want to give radiation if we think it's going to have a benefit. And really the right way to test this is by doing a randomized study. So this is a study that's currently open, and we're trying to get an answer for if we treat patients with radiation early, will it be beneficial to long-term outcomes or quality of life?
Thank you, John. This trial is also listed on our clinical trials page, and I posted a link directly to the clinical trial in the chat. Okay, so moving on to treatment options. First question is to Dr. Ferrarotto. What are the available treatment options for lung metastases? Is there good data to guide which treatment options are better than others? Do surgery or cryoablation ever make sense?
Okay, so so the treatment options, I guess you have systemic treatment options, right? The ones that drug options that circulate through the bloodstream and can attack all the theoretically anywhere, like all metastases. And you have local therapy, as as was just mentioned, with SBRT being one of them. It's hard, there's no consensus yet, but in general, if the patient has oligometastatic disease, as was mentioned, we try to address and attack those lesions. And the definition here, it's usually up to 5 lesions. Regarding local therapy, I guess first, since you're asking about surgery and cryoablation, which one is better than the other? It's hard to say. I feel like, if you have, depends a little bit, if you have 1 lesion or 2 lesions, there's in the same side of the lung, right? And surgery would be a minimal invasive procedure, like, robotic minimally invasive, you can do a wedge. I feel like surgery is the modality that you're taking it all out with margins, right? I would expect, we don't know, that would provide the highest chance of local control because you're taking the lesion out. Now if you have, if surgery entails a lobectomy or it's a bigger procedure, if you have lesions in both sides of the lung where you have to, go both sides, I feel like, a known invasive option like SBRT or cryoablation or radiofrequency ablation would be more appropriate. We also tend to do more stereotactic polar radiation because our experience has been, very good in terms of providing local regional control, more so than cryo or RFA radiofrequency ablation. So we haven't used a lot of that. So it's at least in IMDA, so we tend to do either surgery if it's one shoot the same, only one side, and surgery is feasible with minimal risk, or SBRT if it's usually both sides, depending on location as well. And there are treatment options in terms of systemic therapy as well. I don't know if you want me to talk about this now or later, but can I continue on systemic therapy? Yeah. Oh no. Yes. Okay. So there's really no FDA approved drugs for ACC, but the two options that we can get, it's really chemotherapy or VEGFR inhibitors. So these are the available options, and I know it's not available everywhere. I'm not sure in Europe or South America, it's not always available, but we do have those two that we can obtain, even knowing that VEGFR inhibitors are not FDA approved. I think we have access to this two off the shelf outside of a clinical trial.
Maybe to streamline this, I'm going to ask just a follow-up question, Renata. So, you mentioned some of these drugs. What drugs do you think work best, and in what order, would you take them? Yeah. I mean, we don't really know which one works best. We haven't had really a head-to-head comparison, like, half of the patients get these pills, which are inhibit blood vessel formations, which are target therapy. Half of the patients get chemo, which ones have we see most shrinkage or, make the patients live longer. So these studies have not been done. And even chemotherapy, the studies that have been done were very old. And a lot of times they mix together a bunch of salivary gland cancers, not only ACC. So the data there is not great. I mean, I think both can work. My decision, when to use one versus the other depends a lot on disease burden and how, fast I need to see a shrinkage. I mean, if the disease is more, fast growing and the patient is having symptoms because of the cancer, and I want to try to achieve some shrinkage faster, I tend to use chemotherapy, and the patient can tolerate. I mean, if the patient, has more no symptoms or milder symptoms, that I don't think we need to have a fast response because with the pills takes a bit longer. I tend to use more the pills, the VEGFR inhibitors. So that's kind of one way of selecting and how fast it's growing too. I tend, to use the chemo usually for the most fast growing tumors.
Renata, I think that's a really important point. I think, a lot of patients hear that ACC is chemo resistant and, chemo doesn't ever work in ACC. So what I'm hearing you say is a little more nuanced. There might be larger, faster growing tumors, lesions that might actually respond to chemo, and there may be a role for it. Did I get that right?
Yes. I mean, I definitely use chemotherapy and have seen benefits. I mean, the thing is, when people compare with, head and neck squamous carcinoma or lung cancer or breast cancer, the chances of the major shrinkage, like the 30% or more, is much higher on those cancers, like more than 50%. In ACC, our expectation is more to be on the 20% chance of a major shrinkage, but we do see some shrinkage or stop of or delay in growth, what we call a stable disease, in quite a few patients. I see every week in clinic, I have a patient that is receiving some chemotherapy, and I have had many that benefited from it. So it's not that it doesn't work. I mean, it can work. The chances is not as high as in a lot of other cancers, but it could work. Yes.
And sorry for one more quick. Do you have one or two preferred regimens for chemo?
Yeah, so I do have, I mean, the two main regimens that I tend to use because I think we have more data on that. It's they are both what we call cisplatin based. So one is the combination of three chemotherapies: cisplatin, adriamycin, and cyclophosphamide, which we call CAP. And the other is platinum and vinorelbine. So I think not to say now there's data with gemcitabine, taxanes, and others. So and we don't have had head-to-head comparison, but that's the two that I tend to use, and I have had successes.
Thank you.
Maybe you both could answer quickly next. How do you decide when is the time to treat lung metastases? Is there a certain size that you sort of say, okay, it's time to think about this?
Yeah, I mean, I think there's a few things. One, if metastases are causing symptoms, I mean, I think that really it makes it necessary to treat them. Or if they're in an area where if they grow more, they'll cause problems, for example, to airway or to breathing. Beyond that, there's not, I don't think a cutoff. I think, when they start to grow faster in one area and get a little bit larger, I think we, are more inclined to treat them. And sometimes, especially if we think that we can do it, at least speaking from radiation point of view, in an area where it's safe to treat them, because we're always trying to balance the risks of treating, with the benefits that we're going to get from treating it. So those are the big ones, I think, at least from a radiation standpoint.
Yeah, I totally agree. I mean, these are, I think the ones that there are no controversies. If the patient has symptoms from the cancer is the one. And then, if it's fast growing or if it's not causing symptoms, but if it grows a little bit more, you will, because it's close to a critical structure. Beyond that, I think, the rate of growth, as well, which we're kind of using the 6 months, like in most trials now, just to be sure that the cancer is actually growing, because sometimes if you really can't see, the tumor growing within a certain period of time, knowing that most drugs in ACC cause the disease to be stable, it's really hard to know if the drug is doing anything, right? If the tumor was already not growing or growing very slowly within a certain period of time, it's hard to know if the tumor is not growing, if the drug is doing anything. So we definitely want to see some growth in some of these other factors that we just discussed.
Renata, sort of following up on this, we kind of mentioned it, when are lung metastases painful and what can be done to treat the pain?
Yeah, so lung metastases are usually not painful. I mean, I think the main thing really that we see is cough and shortness of breath. I think these are the main symptoms that patients have from lung metastases exclusively, right? I mean, when it goes to the lining of the lung, then it can be more painful, or if it invades the tumor invades the chest wall, it's when we really see pain. I mean, if it's only in the lungs, pain per se, it's really rare. It's really shortness of breath or cough. I mean, if it goes to the pleura, and gets on the muscle, the diaphragm, or like the chest wall, then you can have pain. And then, depends. Sometimes if it's like only in that spot that you're having pain, actually radiation, it's, can be helpful to control the pain. So you can spot treat that area to help with pain. And nowadays, actually, we have very good pain medications, and we usually refer the patients to the pain experts, and they have, very good drugs that can be used. But it's not very common in general for lung metastases only.
Thank you. Okay, the next couple questions are to Dr. Schoenfeld. How much can you irradiate one site? Can you re-irradiate a second time? Are there tumor locations or the size of the tumor in the lung that cannot be irradiated?
Yeah. So those are all really, really good questions. I think in general, kind of the framework we use is, not just for ACC, but for our whole experience as, in radiation, we have a good idea of, in general, what are the doses of radiation that different organs of the body can tolerate safely. And, there can be differences from person to person. There can be differences depending on other health problems that people have. But by and large, we try to keep the doses of radiation that we give to different areas of the body below the limits that we think are safe. So for example, when we give radiation, we're always very careful that the spinal cord doesn't get more radiation than we think it can tolerate. The same thing with the lung. There's different what we call metrics that we look at, which is how much dose is going to the whole lung, how much dose above a certain, or how much of the lung is getting a dose above a certain, limit of radiation. And so it depends on those factors, how safe it is to give an area radiation. And, unfortunately, some of the effects of radiation are permanent. And so that's why we're a little bit more limited to giving radiation for a second time in the same location. And we generally try to avoid that whenever possible. Not that there aren't exceptions and times when we consider it, specifically in some parts of the body. But in general, we try to avoid giving radiation for the second time to the same exact area, at least a high dose of radiation. We also are careful about the amount of healthy lung that we avoid. So if there's a larger tumor, it's more challenging to treat if there's more healthy lung in the area. So those are kind of the principles we use, so that, that's part of what we do when we kind of do a personalized radiation plan for every tumor and every particular patient, is look carefully at those factors and, try to minimize the risk as much as possible.
So somewhat related to this, would you treat a patient differently if they had metastases in both lungs versus just one side?
Yeah, see, that's when it, starts to depend about how much of the healthy lung is getting radiation. It does, as you can imagine, get hard, because the radiation, when you're giving it to both sides of the lung, or, when there's tumors on both sides of the lung, then it's harder to spare, avoid giving radiation to more healthy lungs. So we can do it, especially if there's small areas that are in different parts. But when there's the more areas of the lung we treat, the more we start to worry about the side effects of giving radiation.
Thank you. Okay, so we're closing in on our time, so we're going to ask one final question. This is to both of you. What treatments on the horizon are you most excited about? Perhaps Renata, you start, and then John.
Okay, so as a medical oncologist in the systemic therapy area, I think I'm excited about a lot of new things. One that I'm really excited about, it's antibody drug conjugates. So this is basically what people call chemo on a stick. It's a smart way of delivering chemo. So basically you find, so the companies are developing drugs where you have an antibody that recognizes a protein that you see more in tumors and not in normal cells. And you can check if your tumor have that specific protein. And then, they make an antibody that is attached to chemo. And then when that antibody finds that protein, then it delivers chemo in the cancer cells, that have that protein in the surface. And in this way, you can deliver chemo at much higher dose in a much more effective way. And they're seeing, a lot of good responses, even in patients that did not respond to chemo when we give directly in the vein. So these drugs have been FDA approved, in many cancers now, breast, bladder. And I think this is an exciting development. We're finding some proteins that are expressed in ACCs, particularly the most aggressive ones where we think maybe chemo works best. And we are going to start some clinical trials with this class of drugs. I think there is also, I think that is very interesting is the bias drugs that basically also finds proteins that are in the cancer cells and try to bring the immune cells close to it to attack. Because we know that in ACC, the immune cells are really not close by, and you have these new drugs that kind of attract the immune cells to the tumor. And there are different ways, that you can do that. But I think that's another very exciting area that I think we're definitely already going there and working on clinical trials for ACC. So a lot in the horizon.
And I guess I'll just add, from a radiation point of view, radiation is obviously very technical. And so there are always technological improvements, such as using MRI or different imaging to kind of more precisely target tumors and account for motion to reduce side effects. And then also drugs that can use combined with radiation. So like nanoparticles, or drugs that are being tested in other types of cancers that increase the sensitivity to radiation. Hopefully will make radiation work better, for lots of different types of cancers, including ACC.
No, I think there's a bridge there between the antibody drug conjugates that Renata mentioned and radioligand therapy that John mentioned. They're both kind of antibodies that find and then they deliver either chemo or radiation, and they're both exciting ways. So unfortunately, I think we're out of time here, but I just want to say, wow, that was an enormous amount of helpful information. I'm amazed that, Dr. Ferrarotto and Dr. Schoenfeld are able to not only push the limits of research to learn more about ACC as a disease, but at the same time, they're able to provide deeply knowledgeable and caring advice to patients at their most vulnerable and needy times. The ACC patient community is just downright lucky to have you both. And I want to thank you both from the bottom of my heart for all the help you've given to ACC patients. And here you're giving up part of your weekend to share your expertise. Thank you.
Thank you. It's really an honor to be here. Thank you for all your support and all the patients as well. We're here for you.
Thank you.
So now I'm going to wrap up very, very quickly. Doctors and Nikki, you may turn off your cameras now. I'm just going to very quickly share our last screen. Hopefully this is coming through. Oops, nope, sorry, I apologize. There we go. This is what we're trying to get to. We want to keep these webinars about education and hope. We need to hear from you, what worked well, what could we improve, and most importantly, what topics can we cover in the future? Please put your thoughts into the chat right now. We're going to keep it the chat open for 5 minutes, after I stop talking, so you can put your comments there, or feel free to email us at info@accrf.org. We definitely want your feedback. So thanks again for joining us, and I hope you enjoy the rest of your day and weekend. Take care.